Okay, well then you are next, so if you'd like to go to the podium, you can start speaking, please. Thank you. Yeah. Now, Rosemary, I gave you a little minute time limit last time. I'll let you go past the 3 minutes. No, but I'll let you go up to the 3 minutes. But beyond that, you know, you're in big trouble with Chuck. Okay?
Well, I don't have much to say because what each of you has been provided is pretty much saying it all. But I will read my introduction. The quackery in the public health system since the American Dental Association in June 1950 newsletter reported the U.S. Public Health Service was then endorsing artificial water fluoridation. My own and one child's experience with a medically prescribed fluoride supplement and my independent investigation of which revealed man-made, unnatural, chemical fluoridation as well as drug-based, chemical-based medicine, which includes vaccines, simply because GMO products included in them or used to produce them are legally absolved from being listed on labels. GMO-produced plants and animals, Frankenfood technology, and Spokane's inefficient health-depreciating waste incinerator all have a common denominator. Okay? That common denominator is fluorides, the compounds that are created when fluorine, the halogen, which is very highly reactive and well, from my point of view, it's a neurotic element, loves to come in contact and chelate with all but 4 on the elemental chart. Now, I've provided your legal counsel with a 2-part DVD and the book that accompanies it, and if you read what I've submitted, it will explain why. Thank you.
Thank you. That's it?
Yeah, aren't you happy?
No, I'm not happy. I'm just proud of you. Yeah, you were well prepared this morning. Okay, thank you. That ends citizen input for today. We'll go to item number 4 on a chair report. There's a number of thank yous I'd like to provide at this time to Keith and the committee relating to our governance committee. And perhaps, Keith, would you like to say anything regarding that committee at this time or not?
Not much, other than a lot of the work we've been working on is this legislative advocacy process, which we'll be talking about some today, and we're continuing to work on that. Hope to continue that work through the end of the year.
Okay, thank you. Also, thank you to Dr. Lutz and his committee regarding the procedure that we are going to be following with the health officer evaluation and the follow-up that we'll be doing. Again, thank you, Dr. Lutz, for a job well done. I appreciate that very much. Also, at the same time, would you or Bob or Kevin would like to say anything about the strategic planning portion of it?
I'm going to defer to you first, Bob, and go from there.
Very well, Kevin. Thank you. And I think Linda might be speaking a little bit to this. No, maybe not. Maybe not. But, pardon? Oh, we always need you. We've been undertaking a strategic planning process. Kevin and I have been involved as board representatives for that process. We had a all-day meeting a couple weeks ago with representation from all of the different departments within the agency. And what was crafted were draft mission, vision, goal, and value statements that should be within the materials that you have in front of you. And so again, it's a good process. It was tiring, but very engaging, and we'll be engaging in the similar process a week from today. Okay, next steps.
Thank you very much. I would like to make a change of the agenda, if I may. I'd like to put the Let's see. And then item number 7, I'd like to now go to relative to the consent agenda regarding the meeting minutes and the vouchers. There are some people that have to leave early, and so I would like to appreciate very much if we could move that item up now, which would be item, I guess, 5. Also, at the same time, I would like to be able to do the an action item 8C, resolution number 4-07, adoption of the 2015 budget. Mr. Riley is not able to be here today. There was an emergency in his family. His mother did have, I understand, a stroke. Is that correct, Torney? And so Torney is going to fill in for him. And so I'd like to have those 2 items moved up because Torney also has a 2 o'clock that he really has to make. So I'd appreciate us, first of all, to go to the consent agenda item and ask for a motion to accept the minute meetings of September 2014 and the vouchers September 1 through 30, 2014.
So moved on both items.
Do I have a second on that, please?
Second.
Okay, it's been seconded. Any discussion regarding those 2 items? Hearing none, all those in favor signify by aye.
Aye.
And those against? Thank you very much.
An abstention, Chair.
No, an abstention?
Yes.
Okay, 1 abstention. Would you like to speak to that?
I wasn't here, so I can't.
Okay, I didn't think so.
Yeah.
Okay, at this time then, Torney, would you like to come up with an action item? We'll take this one on the resolution number 14-07, adoption of the 2015 budget. Please make note that Mr. Pace is now part of the quorum, please.
Well, good afternoon, and thank you very much for adjusting your agenda. We have had a very active and supportive Budget and Finance Subcommittee, which has been chaired by Commissioner O'Quinn. Also want to recognize Mike Fagan, Ed Pace, and Keith Baldwin, who participated in those and have looked at the budget in any depth they chose, have had very many excellent questions for Mike and myself, and what we had shared with that committee is that we would hope that they would be supportive and recommend to this board adoption of the budget. In addition, this was sent out to you in your packet this last week, and I would be happy to address any questions you may have. One that Mike did say that I should probably bring to your attention is the increase to both the revenues and expenditures by 5%, which was something that people had wondered what causes that, and it really is the reflection of 2 key things in the agency. The first is the growth in our opiate treatment program. We have brought on another 150 clients on that. The other is the increase in the dollars that are going from the schools passed through us for the special needs programs, the Gill School and others. We've seen an increase in those dollars both because of a state increase per student as well as increased student loads. So that accounts, those 2 things account for the total increase in the budget, both from the revenue and expense side.
Tori, I don't expect you to have an answer to this, but it sure would be nice to know maybe sometime in the near future, or if you do know off the top of your head, is the increase in the opiate treatment program due to, again, the increase in the use of heroin here in Spokane Town, as reported by the media?
I don't know that I can say that it is heroin. Okay. Certainly there is an ongoing demand for people to get into the program. As you will see, there will be renovation of this building going on to expand that area. We also have included into that a mental health component. And so clearly substance use, whether it is heroin or prescribed drugs, continues to be a major problem in our community.
Thank you, sir.
Okay, Amber.
And I'm just following up on that comment. I thought, though, that maybe we have more people in the program, though, because of the Affordable Care Act and folks being able to access, maybe who weren't able before, some of those services?
That's actually a smaller percentage of the increase than private pays. Our limitation before is one that the county certainly offset for us when they raised the limit of who we could bring onto the program. Now it is our internal capacity to meet that.
And that's
demand.
why we're looking to increase that. So
Correct.
Wonderful. Well, thank you for working on that. It's really important for the community.
Well, great credit goes to Julie Albright and her staff. They do a terrific job.
Just to make a point that the chair of the Finance Committee, Shelley O'Quinn, now has shown up, and so if she needs to take any pressure off of you due to the fact Mike cannot be here, she would be more than welcome to do that. So continue,
Say,
Tony.
Mr. Hafner, that agenda item was way down on the agenda.
I know, but it's also 15 minutes late, Commissioner.
It was 10, 8.
Okay, continue, Tony.
Well, simply, Shelley, prior to your coming in, acknowledgement and thanks to the great work of your committee in going through this in the detail. I did talk about the increase in expense and revenue from those two pieces. But beyond that, we are asking for adoption of this year's budget, and any comments that you would like to offer.
Yeah, the only other comments, I will say that the committee did meet several times, and this year, unlike last year, we did have the opportunity to all meet together many times and work through it. The one item that continues to come up every year is the fee structure, and so we will be forming a subcommittee for anyone who would like to participate in that. Now that we have gone through this budgeting cycle, that will start meeting to look at whether it will be a policy change for the board. Right now, it's 100% cost allocation for fees, which is why we have the structure we do, and the fees that we do. But if we will be taking a review of that. So if you're interested in that, I know it's been an ongoing concern for some of the small towns, and also for even Pig Out in the Park and City of Spokane and those groups. So if you want to participate on that, this is the time to do it, because we will be doing that review and then coming back to the board for the discussion and any recommendations, so that as we do budgeting next year, that conversation has already been had.
Okay. Would you like to add anything else before I ask for a motion to accept this budget? Yes, Keith? Should it wait until the motion has been put into place, or do you have something?
Well, I'd just like to have Tony reinforce the administrative process they go through and how really robust it is, which makes the work of the board then much easier, because it really is a great process. Maybe you could explain a little bit more, Tony. I don't understand I don't remember the name of it.
Logical decisions for Windows.
Yes, but it was very helpful in terms of our work as well.
Okay.
Thank you. I can give you a highlight overview of that. First of all, to acknowledge that we do work our budget year-round. It's not something we prepare for you and then it's done. We do track that budget throughout the year, and a great deal of credit to Kim Kramars, sitting in the front row, who is holding us accountable by reports on a monthly basis. Our process goes through a scoring methodology where we use a product called Logical Decisions for Windows. We as an agency can establish the criteria which we want to score against. Those criteria then are scored by every program in the agency, and based on the criteria, it then ranks them saying, per your values, this is what you see as most important, and here's what you would see as least important in the list in between. That includes factors about all kinds of criteria that are important to public health. So it is about prevention, it is about access, it is about availability in the community, and so it also includes a budgetary component. From all of that scoring, we can then look at any given program by any of those criteria and determine why its ranking is where it is, and that is shared in depth with the Budget and Finance Committee, along with all of the financials that we have on a monthly basis. So it is very thorough, and a great deal of credit to Mike and his crew.
Does that help, Keith?
That does. So I would move to approve the budget.
Okay. Do I hear a second?
Awesome.
Been seconded. Any further discussion? All those in favor signify by aye.
Aye.
Those against?
Thank you.
Thank you very much. Let's go now back up to item number 5, the health officer's report. So Dr. Joel, please. I would like to add a couple items regarding Dr. Joel and the health region. One of the things, hopefully you're all receiving some reports on the Ebola and what's going on and what's happening. And I appreciate very much what your staff is doing in making sure that we as a board are informed so that we can go from there. It helps very much that we can talk to people or in our regards to what's happening not only locally, but really I guess the facts that really are affecting us with Ebola, and knowing fully well that you start talking about it and people can just absolutely come with all kinds of things that are happening, which are really not true because they're not based on facts. So at this time, I think that Dr. Joel will give us a report on 3 different areas: Ebola update, enterovirus D68, and DEA drug take-back regulations. Dr. Joel, please.
Great. Well, thank you, Chuck, for the opportunity to speak to you this afternoon. I was going to give a broad overview of Ebola and what we've been doing here at the Health District. And next I'll talk about another infectious disease outbreak here in the U.S. called enterovirus D68. And I'll finally talk about changes in DEA regulations as it relates to controlled substances. Many of you have heard about the challenges with Ebola and the current outbreak in West Africa. This current outbreak represents the largest Ebola outbreak that we've ever seen, and this is largely due to the poor health and public health systems and over a decade of civil war in this part of the world. And the outbreak is so severe that the World Health Organization has declared this outbreak of a public health emergency of international concern. And also with Ebola, there is no approved treatment or vaccine, but they are under development. General background about Ebola. Ebola is previously known as Ebola hemorrhagic fever. It has been a fairly rare disease, but is very deadly as well. Ebola is only naturally found in several African countries. It was first discovered in 1976 near the Ebola River in what is now the Democratic Republic of the Congo. And since 1976, we've had several sporadic outbreaks only on the African continent. As you've been hearing in the media, Ebola is spread by direct contact with the bodily fluids or blood of an infected person who is symptomatic. And the early symptoms of Ebola include fever, severe headache, muscle fatigue, muscle pain, vomiting, diarrhea, abdominal pain, or unexplained bleeding. All previous Ebola outbreaks have been controlled, and early recognition is a critical part of that control. And since we've had Ebola here in the U.S., there have been significant communication to healthcare providers who are on the front line to make sure that they're aware of the epidemiological risk factors for Ebola. And this includes history of a travel history into the areas in which there is widespread Ebola transmission, or contact in the last 21 days of someone who has Ebola and is symptomatic. So these are the current numbers for the outbreak in West Africa, and the 3 affected countries are Guinea, Liberia, and Sierra Leone. And as of last week, hit a very bad milestone in that there were 10,000 cases diagnosed in that part of the world. And about half of those people did pass away, with about 5,000 deaths. This is another category that the CDC reports out on as it relates to Ebola, the current Ebola outbreak. This is the countries that have travel-associated cases with localized transmission. So that means people were contracted Ebola in West Africa, they traveled to another country, and then cases developed after that. So there are 3 countries in which there are travel-associated cases with localized transmission. Nigeria, in which the outbreak has been contained. There's 1 case in Spain, and in the U.S. we have 4 cases. And those 4 cases include the gentleman in Dallas, Mr. Duncan, the 2 nurses that were infected during his health care, and the ER physician in New York. And so those are the 4 travel-associated cases with localized transmission in the U.S. thus far. So to give you an idea of the history of Ebola outbreaks, these are all the Ebola outbreaks since 1976. And until now, the largest outbreak was the first outbreak in 1976 in Zaire. So that largest outbreak up to now was 318. So with the 10,000 we have, it's on a vastly different scale than what we've ever seen. Some of the activities that we're doing here at the Health District, we're tracking all the different guidance documents that are coming out by CDC and Department of Health and other organizations. We're doing this to help to support other partners in our area so that they have the latest information. We're working with the media to inform the public about the status here in Spokane and such. We've been meeting with other partners and other organizations who may be involved if there is an Ebola case or a suspected Ebola case here. Some of these organizations include the healthcare community, emergency management system, airport, funeral directors, et cetera. We've been working with the State Department of Health to ensure that there is consistency in terms of the practices that the different parts of the state would carry out should there be an Ebola case or suspected Ebola case. And also the State Department of Health has one of the 13 laboratories that are capable of doing Ebola testing. So should there be a need for Ebola testing here in Spokane, we would assist the clinicians in terms of getting those samples over to the State Department of Health laboratory.
Doctor?
Yes.
If you had Ebola cases, let's just say some other cases.
Is your mic on, John?
With similar
Thank you.
communicable properties to it. What facilities do we have here capable of handling patients like that?
Well, there's a couple of things. We're working with all our providers to ensure that they're capable of screening and diagnosing those individuals because I'll be showing you later on an algorithm that have been provided to providers to go through process steps to determine the likelihood of this person having Ebola. So regarding the healthcare facilities here, we've been working with them to ensure that they are prepared to receive Ebola patients. That is a work in progress. I think I'll be going over some additional information later in terms of some of the requirements for preparation for Ebola, and so we're working with those healthcare institutions on that. And also, I guess another part of that would be that the State Department of Health is working to identify about 7 hospitals in the state. These hospitals would be capable of caring for Ebola patients. So the idea is not to have every hospital be prepared for Ebola, but to identify these 7 hospitals and to have one of these hospitals take care of a patient long term if they are diagnosed with Ebola and they would need ongoing care.
So it sounds like we're still trying to figure out which institutions and make sure that they have the right resources in place to do that.
Yeah, well,
the 7, we released out 1 over here.
Yeah, that work is ongoing, and I think the Department of Health want to make sure that all those institutions are on board before we make that announcement. But I think over the next week or so, we will be able to make that announcement. Sure.
Any other questions? Mike.
Just some comments for Councilmember Snyder. About 30 days ago or so, I had reached out to Larry Crowder over at the International Airport, did find out that he was working hand in hand with the Health District. He did provide to me some semblance of a response plan. I can tell you also, being a member of the local emergency planning committee, we haven't been thinking about this up until last month's meeting. So everybody's going to be reviewing, and this would be Air Force, state, emergency management and response, as well as various Spokane County agencies and municipal fire departments are going to be looking at their emergency response plans to see what they can do about fitting some of the Ebola criteria into emergency response. And obviously, the health district for the last 3 weeks has been issuing the sit reps.
Thank you, Mike. Any other questions you might have, Dr. Joel, at this time? Thank you.
Continue on with the Ebola. One of the key areas of the last few weeks have been the area of personal protective equipment, and there's been an evolution in terms of the early recommendations from CDC to some of the latest recommendations coming from CDC. And much of these recommendations came about because of the 2 nurses in Texas who Ebola was transmitted to while they were providing care of that patient. So there is an increased need for additional personal protection, and so hospitals are working to secure this additional PPE, this additional equipment, and additional training that would require.
Dr. Joel,
Yes.
I noticed on the internet this morning that the one nurse that was susceptible to this had been quarantined, and I think she decided to go out and do a bicycle ride. And left the quarantine. Was it ever determined that she had Ebola, or was it negative? We have really cases in the United States that have proven to be that case, other than Delta.
But you're referring to the nurse who was quarantined in New Jersey, but now is in Maine.
Yeah.
She has never had Ebola, and I think the state of Maine and New Jersey before that did quarantine her, and she is currently, my understanding, under quarantine order in Maine. So I'll be covering this a little bit later in terms of the different policies as it relates to what should be done for people returning from that area. So again, some of the PPE recommendations are new that came out last week, and they're more consistent with the Doctors Without Borders guidance. The Doctors Without Borders have been working in the affected countries since the outbreak started. And some of the key recommendations from the PPE guidance is protecting all skin and mucous membranes. So the previous guidance did not require full coverage, but the current ones do. And the current guidance also requires a meticulous systemic approach for putting on and taking off protective equipment. Also requires oversight of someone else while you're putting on and taking off of the protective equipment to minimize the chances of problems during that. And also the CDC requires multiple disinfection steps while you're taking off the PPE. Mentioned earlier that there's guidance to healthcare providers. You can't see this that well, I don't believe. But this is the steps that providers need to go through to screen someone for Ebola and what they should do if the screen is positive for Ebola. So some of the key points is that if they screen positive, they should isolate that person to a room. And they should call public health and put on personal protective equipment, among other things. Chuck, you previously talked about post-arrival monitoring and what that should look like. And as we've seen in the news over the last week, there's been different processes in different states for post-arrival monitoring. Certainly at the extreme end of things, there have been those quarantines by some states on the East Coast. And because of that difference, there's been some guidance coming out by CDC about what should take place after people coming back from the area to the United States, what type of monitoring should take place. So as it stands now, those arriving from West Africa are screened at the U.S. airports, the 5 airports that they all have to come through. They're screened by taking a temperature and doing a symptom check and analyzing what their exposure risks have been. The names and the destinations are taken for these individuals, and CDC will contact the state health departments in the locations where their final destination will be, and then it'll be up to the local public health agencies to monitor those individuals for about 21 days. And the level of monitoring will depend on the risk category that they are in. So the highest risk categories will require more intensive monitoring, and the lower risk categories would require less intensive monitoring. And so there are no current recommendations by CDC for routine quarantine of returning travelers without symptoms.
Dr. Gold?
Yes.
Here in Washington State, are there any statutes that would provide the health district some type of an authority to, involuntarily quarantine or detain, things to that effect?
Yes, the health officers in all jurisdictions have the authority to detain and to isolate and quarantine individuals based on the risk to the public, mainly based on the risk to the public. I think one of the key issues here is that those individuals who come back are generally not symptomatic yet, so that's why we put the monitoring plan into effect, to monitor them, to follow them closely daily, because the individuals who are asymptomatic are not infectious. So once they become symptomatic, that's when the system comes in and we isolate them and put them away from other people so they're not able to potentially infect other people. But there are statutes that would allow isolation and quarantine. So in terms of the current status here, there have been no cases of Ebola here in Spokane County, and no cases are currently being monitored in Spokane County either.
Any other questions for Dr. Dorn regarding this matter? Thank you.
Quickly, enterovirus D68. This is another infectious disease outbreak that's been in the news as well. Enterovirus is a non-polio enterovirus. It was first identified in California in 1962. And over the last several months, there have been outbreaks of enterovirus affecting pretty much most states in the U.S. And with over 1,100 samples testing positive, and including two positive cases here in Spokane. For enterovirus 68, most of the symptoms are mild, kind of like a cold, runny nose, fever, cough, those types of things. But what tipped off public health officials was that there are severe symptoms as well. Hospitals in the Midwest were receiving increased numbers of hospitalizations for difficulty breathing and hospitalization for several cases. And subsequent testing found enterovirus D68 as one of the causes of that. And it generally affects young children and teenagers, and there is no specific treatment for enterovirus D68. This is one of the CDC maps in terms of activity, and Washington is still rated in the elevated category, but we've seen a decrease in activity as we normally see a decrease at this time of year with enteroviruses. And we don't have an increased number of respiratory hospitalizations in Spokane at this point. And finally, I'll talk about the new DEA regulations as it relates to drug take-back. A little bit of background. The Federal Controlled Substances Act previously allowed limited options for disposing of controlled substances, and controlled substances are medications for which there's abuse potential, like opioid medications, Valium-type medications, those types of things. And the previous regulations only allow three options. They could surrender it to law enforcement. They could take drugs back on the twice yearly DEA-sponsored drug take-back days, or they can dispose of these medications themselves, generally through the garbage. And because there have been a significant increase of prescriptions for controlled substances, this these old regulations resulted in increased accumulation of these controlled substances in medicine cabinets, making it easier for abuse, misuse, and diversion, and possibly accidental ingestion by young children. So the new regulations were passed about 6 weeks ago, and these are the key components. The drug take-back days continue, sponsored by the DEA. The new components are the mail take-back program, the mail-back programs, and the locations that will be allowed to have receptacles on site. The mail-back programs will allow certain DEA registrants to offer mail-back programs, and these registrants include drug manufacturers, distributors, retail pharmacies, and hospitals and clinics with on-site pharmacies. Another part of the regulation will be a vast expansion of the entities that will be allowed to have collection receptacles on site. The new areas in which there will be collection receptacles allowed would be retail pharmacies, hospitals and clinics with on-site pharmacies, long-term care facilities in collaboration with retail pharmacies or hospitals, and narcotic treatment programs will be allowed to have on-site receptacles as well. And this is in addition to keeping the on-site receptacles with law enforcement, should there be desire to do so. In terms of where we stand in this community, initial conversations with retail pharmacies, they are resistant at this point to have receptacles on site because of the history of previous burglaries for controlled substances. So there's kind of initial resistance at this point. But this is also a key initiative of the Spokane Prescription Opioid Task Force. And they are working on this topic as a priority. And we as public health are members of that task force, so we'll be moving forward to see where our community lands on that.
And anything else, Doctor?
Mr. Chair?
Yes.
Doctor, you hit it out of the park.
Yeah. Okay. Okay, thank you very much. At this stage, we're looking at a legislative report from Linda Graham, please. Linda?
I have no idea.
And I also believe, Linda, that you're going to have a report on distracted driving at the same time. Is that correct?
Yes.
Okay, thank you. So you do have that in your pamphlet, in your packet, distracted distracted driving that we'll be looking at, and also then the legislative agenda. As you can tell on the packet that you received, and you can see Linda has done an exemplary job of getting all the materials available. The Governance Committee had quite a debate on how to go about this and try to simplify the whole process. And I think as you look at what Linda and her staff has done, and with the comments made from those board members that were involved, that it was a very exciting time. And I think you'll find that this report is going to be very exciting for us to be involved in the legislative session in a much better, methodical way. Thank you very much. Linda?
Thank you, Chuck. And thank you for saying that I have staff, because apparently I'm now told I will get some. It's news to me. But I just really want to thank the Governance Committee for the help in putting the processes together for this work. They've put a lot of thought into it and have been a really good sounding board in helping perfect this process. So today I just want to cover briefly where we're at in the process, talk about the criteria that we've used to develop the legislative agenda, and kind of cover our full agency activity list, which is broader than the proposed Board of Health legislative agenda. And do have the opportunity of an expert here to talk about distracted driving for just a few minutes, so we'll make that a part of my presentation as well. So in terms of where we're at in the process, if you recall, back in September, I brought you an initial list of things that we've been looking at as a district, along with all of our partners, to get initial reaction from you on those. And now in October, I'm coming back with my proposed ideas for your legislative agenda and to have some discussion. but the actual vote on your agenda won't take place until December. So that's where we're at. And the criteria, these were in your packet last time and again this time. These are criteria that we've used for selecting items to put on the action list. They've also helped us to identify the items for your legislative agenda. And they've been instrumental in helping us to determine priorities for action on all these items. And it's really to be based on a balance of all these considerations. It's not meant to be a checklist that an item has to meet all of these criteria in order to make the list. It's not necessarily scoring. They're just some things that we think about when we're deciding how much effort we want to put into an item in the legislature. So any question on these at this point? Okay, great. So the agency activity list, this is what's in your packet as the very large spreadsheet. These are the items that are currently on our radar screen to be keeping an eye on in the legislative session. We have broken them out into 3 categories. Those that we will put a lot of active support in, where we will be really working with our legislators on these items, perhaps making trips to Olympia, doing a lot more work there. Items that we will put some support into, which is when we have the opportunity and the chance, we will be supporting them. And a whole lot of items that we are monitoring, just to keep an eye on what's happening out there and seeing if at some point we may need to take some kind of an action on them. So this is that full list. Last time, one of the things I asked for were those items that you wanted additional information on. And also in your packet are just some one-page overviews on these that talk about an overview of what the policy is, what the public health related goal is, and then a quick summary of the opposition. And one of the items that you had wanted more information on was distracted driving. And so we had the opportunity to have over an expert who's done some research into the issue and has been working on some policy at the state level to address that. So at this time, if it's all right, I'd like to have Beth come up and talk you through a few things. She principally right now is with the Harborview and Injury Prevention and Research Center, also with the UW School of Medicine. She also has her MPH, so is very familiar with public health issues. And really the connection here with public health is we do a lot of work around injury and death prevention. And that really ties into vehicle-related incidents and accidents, and including distracted driving. So I will get this off, and start yours.
Thank you very much. I promised to be brief because I know you have a full agenda, and I really appreciate the support of folks from the board to allow me to talk, and Mr. Chair. We see kids, adults for distracted driving and take care of them over at Harborview from all across the trauma region, which is basically a quarter of the U.S. landmass. It's a big reach. And this is one of the areas where we provide treatment, but we sure wish we could prevent injury on the front end. And it's a policy, it's really the policymakers and our legislative leaders who can make that happen. And so I appreciate the opportunity to talk with you. I'll spend just 1 minute here to show you a little video, if it'll pop up for me, of distracted driving.
And oftentimes we'll find one or the other.
He's still sitting there. He's still texting, and he just realized it turned green.
So he's waiting. Watch him drift into the white line here.
Across the white line. You weren't texting?
I had the phone on like this.
Yes, sir.
Looking at my trades like this.
Looking at your trades?
Yeah.
When a driver is talking on the phone, the crash risk goes up.
So we talked about that. So part of the challenge that we have is that the current laws, which were really innovative at the time, haven't kept pace with technology. And that's what we're really interested in, is seeing what are the opportunities to update these laws. When the distracted driving laws were passed in our state, we were flip phones. I mean, you all probably remember those big phones that people are carrying around. They did not anticipate that it's a computer and all the things that could be done. So what's the upshot is that the laws that we have right now don't cover a lot of the conditions that can be pretty challenging. So just very briefly, the current law is written so that if you have a phone to your ear, it's covered, but this is not. But this is not any safer. And it creates a real challenge for law enforcement. You know, the police officer is going to pull you over for this, but not for this. The law covers texting. It does not cover posting to Facebook. So an officer can pull somebody over and they can say, you know, I'm posting to Facebook, I'm watching a video, and there's really no recourse under current state law. I think the other piece that's been important is that the federal government has laid out the criteria for what a distracted driving law should look like, and along with that comes federal highway dollars for education and enforcement. And that was laid out under the MAP 21 provisions with the highway traffic funding. So part of the interest is to see what are the options for bringing our state up to speed so that the law is consistent or meets those federal guidelines that would allow Washington to pull down resources for education and enforcement. And I wanted to chat with the Board of Health about this to consider, to get your feedback, and also to consider what are the opportunities for those of us looking out for public health, recognizing that this is a big problem for our largest killer, for all people, and trying to figure out if there's some ways that, you know, leaders, policy leaders can take some steps to keep folks safer on the streets in Washington. So apologize for the technological challenges here, but I'm happy to answer some questions.
Any questions you might have? Board? Okay, John.
So we actually discussed this a little bit at Aging and Long-Term Care, which is a 5-county agency where most of our board members are rural county commissioners. And the first thing they said was, this stopped me from using my Bluetooth phone when I'm driving, you know, a couple hours between meetings.
Mm-hmm. Yep.
And my reading of it is that it does not. It's a handheld use of electronic devices. And that is the change we need to make to come into federal compliance. Is that your understanding?
That's
as well?
absolutely correct. The interest is only to cover the handheld devices. And, you know, I think it's not to say that there's not, you know, some cognitive distraction or some other risks, and people are going to have to use some judgment on it. But it's really trying to look at the highest risk that we know happens with the handheld devices. And in the meantime, you know, there's going to be additional pressure on the vehicle manufacturers, the device manufacturers, to find some ways so that technology continues to evolve more safely. That, you know, the horse isn't going back in the barn. So, you know, we're really trying to do a smart person's job of dealing with the high risk, and then, you know, really working with that technology to also try to keep us safer down the road.
Okay.
It's a good question.
Any other questions? Okay, thank you very much. Linda?
Yeah. We're having strange technology days here. I don't know. Hey, look, mine works. So back on proposed legislative agenda for the board, I've broken this out between budget issues and strict policy issues. Again, this is based on those criteria that we were developed in conjunction with the governance committee. Also from some initial input I got from you at the last meeting about things that you were particularly interested in. In terms of budget issues, I think a lot of you are aware of the work that's been done over the last couple of years, really looking at foundational public health services. Really, this is all about what are those core services that all local public health jurisdictions should be providing, coming up with a price tag for those, and that would be the ask of the legislature. Not entirely sure at this point if we're going to roll forward with that this year. They are working on that right now and kind of assessing the legislative environment and all of that, but it's on our radar screen. Behavioral risk factor surveillance system, affectionately known as BRFIS. This is a very critical resource for us here at the Health District and also local health statewide. And really the funding is critical to getting the data at such a level that we're able to break it out by demographics, which really helps us look at disparities. And then recreational marijuana. As you're probably aware, there's some funding under I-502 that comes into public health for prevention and education, for some research, and the Healthy Youth Survey, which is also another really important resource to us. I think there's going to be lots of efforts this session to rearrange the provisions under 502 about who gets the funding. So this is really about really trying to protect what is already dedicated to us. So comments on budget issues? Anything else to add? Any concerns about any of this?
Okay, Keith?
Well, could I just say, for some of us who use data a lot, this BRFIS data, I think is really important just from the standpoint that it is so hard to get current data. I know our epidemiologists here really work so hard, and yet it's so hard to get current data. So I would just put in an extra plug for that, because it's so important to have that, to be able to do policy issues. Without data, you're just lost. So.
Thank you. Any other comments?
I know Lindia, the director of the department that contains the data centers, back here smiling when you said that. So.
Okay. Amber?
Well, I just want to add on to what Keith had to say, because a lot of the BRFIS data is survey data. It's more, I mean, in my mind, like qualitative. What is your sense of security? And it gets at a lot of youth issues too. That it's hard to get that information about if our youth are using drugs and alcohol, and that helps us make our programs better and align our resources better. So it's really, I agree with that. That's a top priority.
Great, thanks.
Any other comments, Dr. Letts?
Yeah, I would just like to make a comment about the tobacco omnibus legislation. I attended a conference 2 weeks ago, at which time a representative from the FDA spoke about the challenges that FDA undertook to make tobacco a regulated substance. It started in 1996 and didn't get passed until 2009. Some of the statistics, though, and some of the language that he spoke to were very fascinating. So he said that it's been found that 90% of people get addicted to tobacco before the age of 18. 3,200 kids light up daily. And looking at the language that was used by the tobacco industry, they referred to youth as quote-unquote replacement customers. So when the tobacco industry, when their internal memos were released, they were, again, euphemistically referring to children as replacement customers, identifying and recognizing that if they could get them hooked early, they had new people to take over for when those people who were dying from tobacco-related diseases passed on. So again, I know it's still kind of a conversation right now, but I think, New York City did increase the legal age of tobacco purchasing to 21 back in 2013. A lot of pushback, not surprisingly, but I think it's certainly worth looking at. So,
okay, thank you for those comments.
So, and then looking at the rest of the policy issues, a lot of work being done on e-cigarettes, licensing requirements, taxes, child-proof packaging, labeling on the packaging, and then some revenues then dedicated to education prevention programs. The tobacco omnibus legislation, again, increasing license fees and fines and having that dedicated to public health, and the idea of raising the minimum age to 21. At this point, both the governor is really looking into these issues, probably including all of that in one large governor request. There's also a representative who is working particularly on just the e-cigarette side. So we're not sure yet if we're going to see one bill, two bill, or three. But in terms of just general support, this is where we're landing, and I'm recommending that the Board of Health include these. Also, Shelley, I'll be curious if you had any updates on the next one, the mental health substance abuse system reform, because I know you're on the state subcommittee here.
Right, we won't come out with our recommendations until November 14th.
Okay. And as we've talked before, a lot of this is a work in progress. We don't have bill numbers yet. A lot of this isn't written out. But it's really kind of recognizing that these are going to be public health issues that are going to be out there in some form or another. So I will continue to update you as we move forward. The next item is medical marijuana, really looking at reforming the whole system of how that's working. And then distracted driving, I've also included as a recommendation on your priority list. So comments, discussion?
Okay, this is not decision-making time. Oh, go ahead, Al.
Well, I just wanted to get a little bit of background, if you don't mind.
Sure.
And I'm not a cigarette smoker, never have been, never will be. But on the e-cigarettes, are they currently regulated at the same level as cigarettes are?
There's basically no regulation.
No regulation at all?
The FDA, FDA's come out with some draft rules. The reality is that it's going to be at least a couple of years, if not longer, before those ever get implemented.
Okay.
And then they have provisions in there that it's even once they become law, there's a couple of years delay before certain things come into effect. So it's really wanting to take action now, particularly focusing on youth exposure to e-cigarettes and youth use. What they're seeing happening to a certain degree is that students use these because they're cool. They see celebrities on TV using them, and not even realizing there's nicotine in there or other harmful chemicals. And then they get addicted to the nicotine, and they're actually seeing kids taking up smoking after that.
So the ultimate goal then is to apply the same kind of regulations to the e-cigarettes that you have for cigarettes?
Fairly
more
similar.
Or less restrictive? I'm just trying to get an education about where this is going and stuff. So
I'm certainly wanting to implement a license requirement for retailers, which is similar to tobacco, and the fees for that, the compliance checks and the fines, those kind of things, trying to make those very similar. Taxing of them in a way similar to the tobacco products. And particularly, again, some of the details are a little different from tobacco, is restricting use of flavors, child-proof packaging and warning labels. I mean, some of that is consistent with tobacco, but it's kind of a little bit different there. But again, a lot of then having some funding stream going towards the education and prevention programs like we have with tobacco. But they're a little bit different in some details, but generally trying to make similar regimes. The one thing at this point that is different is smoking, which would be covered under tobacco or smoking marijuana. Any kind of smoking comes under our smoking in public places law. At this point, e-cigarettes do not.
So,
you have a question?
I've got a couple more, if that's all right. But I think Bob had something to add to the conversation. So.
Well, actually, Linda just sort of mentioned it, because, again, I think that one of the opportunities, there's a number of communities across the state that, across the country that have enacted e-cigarette legislation, and one of the opportunities especially exists around the Clean Indoor Air Act. So right now, there is no regulation, nothing that would prevent somebody from smoking indoors, but where opportunities exist is by making use of that act and then preventing them from smoking indoors.
Yeah, and at this point, in talking with all the various partners out there, a lot of hesitation at going after that at a state level. But one of the things I would like to be working with the Board of Health on in the future is potential local regulation of including e-cigarettes under our enforcement of smoking in public places. King County has done it, Grant County, I believe Tacoma, and I know Snohomish is looking at doing that as well. So.
And the one thing about it right now, in the draft FDA legislation, they do not address that issue. And so that's outside the scope of the FDA guidelines, FDA regulations. So that would be something that local communities could, undertake.
And one just last point on e-cigarettes. A lot of this really is focused on youth because of the uptake and the changeover, as opposed to adult use. And one of the things I did want to point out is a lot of people believe that these are proven to help with cessation of smoking, and there has been no evidence that shows that that's actually a fact.
So as the conversation matures, one tool that would be helpful from my standpoint would be kind of a side-by-side, like a little chart that says, this are the regulations that apply to cigarettes, these are the regulations that apply to e-cigarettes, so that we get a differentiation about how these are to be applied and stuff, and that would be helpful to understand how we're moving forward. And
Great,
stuff. So,
happy to do that. And one of the other things, just to let you know, is we've been talking about really trying to sync up the systems around e-cigarettes, tobacco, and alcohol. If you look at the fines right now for selling to minors, tobacco is about this much as opposed to what it is under alcohol. There are no fines under e-cigarettes. And so really trying to bring those up on par as well, and also including the age restriction in there. So it's all on similar level.
So I would be very, very much in support of trying to get parity between the two products in terms of how we're treating them and stuff, because anyway, on the tobacco omnibus legislation, the only challenge I have, and I'll tell you, I've had it ever since I was in the Marine Corps, is if you're willing to lay your life down for this country and you can't smoke or drink, that's just nonsense to me. So I'm not going to be able to support the age limitation and stuff. So just put it out there. And distracted driving. Is there any efforts from an industry standpoint? I mean, if you get into your car and you turn it on, your phone automatically syncs up to, the hands-free for most of the new cars and stuff. But it seems to me that, you've got devices that prevent you from starting your car up if you're alcohol impaired. It seems like there should be a similar kind of device if you're a youth or, some other kind of conditions that would make that technically challenging, as opposed to trying to create more and more regulations that make it more challenging for our police officers to try and enforce on the road while they're watching everything else.
Yeah, and
stuff.
I'll turn to Beth on that. I believe we were talking a little bit about that earlier. So, and back on the issue about the raising the age to purchase tobacco to 21, I would encourage you, in your packet is some details on some research that has been done about the population of smokers and what the difference it could be. And so from a public health perspective, again, it really is about trying to prevent a lifelong and life-shortening addiction to tobacco that has cost not only for the individual but on society as well and health care.
So does enlisting in the military does the same thing to your life? So, I just put it out there. I mean, fundamentally, I've got a real challenge with the idea that we're going to infringe upon freedoms of folks that are willing to fight for this country. I just cannot go there.
Okay.
All right.
John.
Thank you.
So, Commissioner French, just so you know, this process will allow us to take up or down votes on specific issues. So you'll have, and everybody will have an opportunity, if there's an item like that they can't support, for us to do that. So Linda, my comment on this is too short. Like, we have almost as many health-related agenda items on our city as Spokane legislative agenda, and there's 3 things that I'd like to see added to here.
Okay.
Maybe kind of 3.5. I'll give you the half first, and that is, so I'm on the Washington Traffic Safety Commission, and the distracted driving thing is a big priority for us too, and it's kind of a 2-part thing to get some federal money back. Last year we did some changes to ignition interlock device law that allowed us to get some federal money that we were missing out on, and if we can do this to the distracted driving law, we can get that benefit as well. So I'm real strong in support of that. But another thing that Traffic Safety Commission is putting forward that I think is actually real likely to get some action and would be a really good thing is an open container style law for marijuana. So basically right now, if you technically your car is not a public space, and someone in the car who's not driving can consume marijuana in a way that they couldn't consume alcohol. Right now, you can't have an open container. You can't be drinking in a car as a passenger when you're in a car. It's not the same with marijuana. And I think that's it's a kind of budget neutral, pretty easy change. Just allows people to understand that it's not okay to be doing vaporizing or smoking or any kind of ingesting in a car. So I would suggest we maybe add that to our line item under recreational marijuana. 2 other things that I think are one real likely to get some action is the rail safety item. We had our legislative roundtable yesterday, and Senator Baumgartner was there, and he mentioned it a couple different times. And there may be differences of opinion on what's the best way to approach this, but I think there's some pretty strong bipartisan support in both sides of the legislature to do something on this year. So to me, that would elevate it to something we want to put in our legislative agenda so that we have a chance to influence that. The second one is a transportation package. We have a couple different priorities involved with the transportation package, and I still think there's going to be a desire to look into doing that. As long as it remains a really high priority for the governor, even though the McCleary decision is occurring this session, I think that is another one. And the last one, which I think...
That's 4 now. You're going to go to 5? No, you can go ahead. You said you had 2 extras. I've listened to the 4 so far.
That was my 2.5, Chuck. So here's my 3.5.
Okay.
And that would be the item on paid sick leave. establishing minimum standards for safe sick leave and safe employment. I think it's really timely with all the communicable disease discussion we're having. So those would be the 3 ones that I think I would suggest adding.
And I would really appreciate input from anybody on those suggestions or any others you might have, whether items are on your big spreadsheet or other things you know of. Let me know, and then have some discussion about whether you might want them included for the next go-round. Just to let you know, I did meet with Senator Billig this morning, and he is very interested in continuing to push on transportation revenue package with some specific funding for things connected to us, safe routes to schools, complete streets, those kinds of things. So because of his particular focus on that, it's in the criteria of local legislative action and those kinds of things. So
Ed, you have a question?
It's kind of raising up.
Thank you. Just some comments. First of all, I agree with what Commissioner French said about age limits. I was in the Army when I was 18. And I just agree with him. I don't want to mess with that. Secondly, I'd like to see all of our focus, whether it's here or whether it's on our legislative agenda. I mean, this whole list is good. It's impressive. But I'd like to see the focus be on more on educating the public, informing the public, rather than messing with the public's lives or getting into the public's lives. And also just a comment on a couple of the things here. I'd really like to see us make the mid-level dental provider thing happen if it ends up with lower cost dental care for our citizens. And then second, the mental health piece. I'd like to see us work on rolling it back to the way it was before all kinds of mental patients ended up on the streets. And, our state constitution calls for providing mental health care, and I think addiction is a subset of that. And I'd like to see us roll back to the 80s or the 70s or whenever it was that we could be assured that mental health patients would have a place that they could live safely and be treated and
Okay. And we'll look into that, sure. Yeah. Linda, would you talk about the process that we're going to be doing at our next board meeting? I think John brought it up of how we're going to have a selection process relative to the numbers of legislative items that we may want to do. And will you take about 5 minutes or so and discuss that a little bit?
Yeah, basically, it's your decision on whether you wanted to add other things to this list or take things off. These were just my initial suggestions to start a conversation. So I need some input from everyone on the suggestions that have been made about potentially adding open container style law for marijuana, rail safety, transportation revenue package, paid sick leave, mid-level dental providers to your priority list or not, or if there were any other suggestions of things to put on or take off.
Okay.
And then I will prepare that for the next meeting, and then we can vote.
Any questions regarding that?
And the other input was, do you need any additional information on any of these items, like the one-page fact sheets or something?
Keith?
Yeah, I was wondering if I could get more information on this Healthiest Next Generation program. I sort of missed that the first time around and don't quite understand that as well as I'd like.
Sure, I can get you that. Basically, it was a governor's initiative that came out last year, really focusing on youth obesity prevention and really working within environments such as schools and day cares to address physical activity as well as nutrition. So I'll get you some more details.
Okay. Shelley?
Just a couple of comments. I would agree with John Snyder regarding the marijuana. Maybe we can make it a broader category if we wanted to include the open container type law under. I do like the idea of keeping a shorter list, so I'd rather just expand the marijuana category up there and add those recommendations. I think as we go in this next legislative session, we're all going to be battling to keep what we have. Almost a do no harm mentality because of the mandates around K-12 education funding. And so I would hate for us to go in too broad. I'd rather have us focus specifically on the 3 budget items, and then our smaller listed policy issues. And we do have issues that we've agreed to, actively support and monitor. I have a question regarding monitoring. It says monitor status and take action as appropriate. I would like to know what you mean by take action as appropriate. Does that mean it's coming back here? To move it from the monitor category to the actively support category? I'd like some more clarification around that. But I personally like the idea of keeping it small and focused.
Well, I think the other thing, we want to do it right. And so make sure that we are informed of what we're going for. And so we need to be educated in all those items, like the information Keith asked for. So you need to relate that to Linda. Any other new ideas or any ideas? We certainly would like to look at that. Amber?
Oh, I just wanted to follow up on Councilman Snyder's comments on the rail safety issue, because that did really come out in the conversation the city had with our local legislators yesterday. And I was just wondering if there was a reason why you thought that one wasn't, I looked at your notes at the uncertain of current political climate around the issue. Is that just something you haven't delved into a little bit lately? Okay.
Yeah.
And I was just wondering what your take on it was, and in relationship to the other issues that you elevated onto the agenda.
Yeah. I think part of it was the central connection to public health of some of the other issues made them a little more central. Part of it was also some discussions that have happened here, and then also tracking down where things are at with some specific people in the legislature and some other partners to find out where are things at, is it going forward. So at this point, I don't know enough about exactly what's going to go forward. So it didn't rise up there. We can certainly move it up as an issue to put on your agenda.
We may have some local legislators that are really working on it. So I think it may be an opportunity to partner with them. If we didn't have any local legislators that were, leading on the issue, I would say, well, maybe, but since they are, and since we're kind of the hub for the pinch point for all the rail coming through, it might be something to highlight if we get that information back on it being a likely topic for 2015.
Okay. Any other questions? John?
So I would just, I thank Commissioner O'Quinn for input on that. I would just request that we get to vote up or down on all the suggested ones, Ed's priorities, my priorities. And it doesn't sound like there's a lot of, other than the raising the age to 21 on this suggested agenda, it didn't seem like there's a lot of concern or controversy about the other things on here. So maybe this is still a starting point, but I think I would like to have up or down votes and everything else. I actually don't have the concern about having it be too big, precisely because we only have really 3 budget issues. Some of the other issues we're talking about are either budget neutral or budget positive, which could possibly be something that's with new fees established in the rail safety thing and whatnot. And this may be a really good session for budget neutral items where people are looking to pass stuff when there's no budget impact. When you've got some really huge budget discussion going on, folks sometimes look for budget neutral items to just get done in those types of sessions. So I don't have the concern about expanding the list.
So what you're suggesting, John, is that we have voted up and down on all the items that we have at this stage. Is that what you're saying?
I would say all the ones that have been suggested to add to this or subtract to this list.
And Shelley, what was your recommendation?
I just recommended keeping it to a one-pager. Keeping our priorities short.
Okay. Okay, by consensus, then let's find out how many by consensus do we go with what John would like to have relative to all of the list, and so we have an up and down vote on December the 4th, or we would keep our short one at this point in time. Is that what we're saying? I don't know that we need a motion, but maybe we need a consensus.
I'm not suggesting any action today. I'm just saying
we're not recommending action today.
When Linda comes back with the more information and we're starting to look at the list.
On December the 4th, then, when we come back again. Okay, yeah. I didn't understand that.
Yep.
Yeah, and I didn't, as I listened to Councilman Snyder and Commissioner O'Quinn, I did not hear that what they're proposing was mutually exclusive. John's was more about process, and I thought Shelley's was more about outcome. And so, how we get to the outcome is, an up or down vote on all the items and stuff. So, but I didn't see them. I don't consider them mutually exclusive.
Well,
Ed?
I thought I heard. Actually, I agree with both Shelley and John. But I thought I heard John say the up or down vote on just the top ones, or did you mean up or down vote on every single item? Because that's what I'd like to see, up or down on everything.
We could do up or down on every one, but the way I would do it is I would say, if you have a concern about anyone on that list, request that it be pulled out for an up or down vote. I don't personally have any too much concern about anything that's on the list, the short list that Linda has already given us. So if there is a concern, and we've heard concern about one item, maybe pull that one out, and then all the other ones that me and Ed have suggested should be up or down.
I'm curious, Linda, on the tobacco one. Is there, if the group decided, could the piece about the minimum age be pulled out and everything else in there kept in? So we wouldn't have to just pull the whole tobacco legislation piece off. Correct. We could just decide, if depending on how the vote went, whether or not the age limit was included in that or not, correct?
Mm-hmm.
Correct.
Okay.
Do you have all that, Linda?
Yeah.
Okay. Any other questions of Linda? Okay, thank you very much.
All right, thank you for your time.
Are you through?
I am done.
Okay, thank you very much.
I will see you in December.
By the way, what a great job you've done in preparing all this information for us, Linda. We now go to action items. Item number A under 8A, and that's the 215 chair nominations for council member for chair nominations. I think that we adopted by resolution September the 25th, 2014, chair responsibilities. I think that was in your packet. I think there were 17 that was specified as to what the chair should be doing or not doing. Also, under the vice chair, there were responsibilities that not only did he have about 6 of those, but they all related to the chair's responsibility. We also then, in your packet, the guidelines were that hopefully you would the person would have sufficient experience on the Board of Health and so forth. I won't go through that because I'm sure all of you have read that. And so the process that we had determined by our bylaws, of course, was that we would take nominations today from the floor, and that if there are more than one nomination for the chair or the vice chair, then come December the 4th, we would do a ballot measure to vote for whomever the 2 people would be, whether it's for the chair or to the vice chair. So keep in mind that the people that have been selected for this board are not qualified to run for the chair or vice chair. It's just the elected members of this board are the ones that are qualified. So are there any questions regarding those qualifications? That being the case, I would open up consideration for nominations for chair.
Mr. Chair.
Mr. Pace.
I'd like to nominate Commissioner French for chairman of the board.
Okay.
Could I second that just to see his reaction?
You're going to get a reaction without the second.
Remember, the person has to say yes. Okay.
The challenge that I've had with this board is that I have another board that I represent the board, Spokane County on, that is a 9-county board, and I'm the only one that represents the county on that board, where on this board we have all 3 of us. And so that's why, I can defer attendance to my other colleagues and know that they will carry the ball admirably in my absence. For me to chair this board means I've got to step off the other one, and I've been on that board for 4 years, and so it would be a challenge to try and do both.
Why can't we shuffle meeting times and dates of either that board or this board?
It would end up having to be for this board, because that board, like I say, is 9 counties, and so 8 county commissioners travel once a month to Spokane to have that meeting, and I would hate to put that burden on all of the rest of the members of this board to try and adjust their calendar for me.
Understood. And
that a yes or no?
I would like to suggest,
I'm getting to the
before
no.
you get all the way, I'd like to suggest that we separate these two out. The selection of the board chair and then the scheduling of meetings. Do it in two pieces. So if you end up as the board chair, then okay, let's tackle the scheduling issue then.
I had nothing to do with this, but I'm supportive of the idea.
It's interesting because I just sent a note to Councilman Hafner here earlier that said I've served on this board for 12 years and I've never chaired it, and I've never had, to be honest with you, a strong desire to chair it because it's a big demand and stuff. So with 32 boards that I currently sit on, and then putting another one that's got a big demand, it would be a real challenge. But I appreciate the vote of confidence or the lack of any other survivors.
It's a vote of confidence.
Yeah.
So you're saying?
No.
No. Okay. Are there any other nominations?
I'd like to nominate Councilman Snyder for chairman of the board.
How does this process work? Do we put out multiple nominations, or?
The nominee,
Sorry, I don't
according to
know.
our bylaws, has to accept the nomination if they wish to be, for December the 4th, be voted on at that point in time.
Right, but what I'm asking is do we go with one nomination, or if I want to nominate?
You can do as many nominations as you want.
And then they all go forward.
And they go forward to the vote on December the 4th. That's correct. So John has been nominated. Do you accept?
I will accept. I just have to look at, I was expecting to be nominated. I just have to look at my schedule and see how I can make the proper arrangements, but it doesn't look like there's any other nominations coming forward.
I was going to nominate Mr. Hafner as well, and if he would be willing to serve a second term.
I will accept. Anyone else?
Yeah, Mr. Hafner.
Yes.
I remember, I think it was last year or the year before last, we were able to nominate Commissioner Milkey when he wasn't here. And I'm struck by the fact that opportunity exists again.
I think it'd be funny just to give him that note.
No. Okay. Are there any nominations for chair? Okay, John, you accept?
Well, if
And
you
I
don't
accept.
I'm going to withdraw because I'm very quite pleased with you.
Don't let that make the decision for you, So
Let me have another question, though. Is Mr. Freeman is now...
he's next up for nomination. I mean, for the vice chair. Okay.
So I'll withdraw at this point.
Okay. Ooh. Okay.
I'd be happy to discuss with you.
Are there any other nominations? And I close nominations for chair.
No,
Okay. Nominations now are open for the vice chair. Do I hear some, please? Amber?
Well, I would nominate Mr. Freeman, Mayor Freeman, for vice chair.
Mr. Freeman?
I'll accept.
Are there any others? Hearing none, nominations are closed. So next, in December the 4th, we will then vote either by unanimous or however you would like to do it, but the bylaws said we have to vote on December the 4th. So that the two nominees so far would be myself and Kevin. Any other discussion regarding that?
Wasn't one of the requirements that the person be on the board for a while? And Kevin's pretty new, right?
For the chair.
Oh, for the chair, not the vice chair. Okay, cool.
Yeah. Okay, any other comments regarding that? Okay, let's click on next item as 9A. Susan, you're finally on.
I know, and I think I'm standing between you and the end of your meeting.
No.
Okay. Let me see if the technology will work for me. Okay. Thank you for having me this afternoon. My name is Susan Joberg. I'm a program manager in disease prevention and response. And I am here to talk to you not about Ebola, which has consumed my life for the last 3 weeks, and I'm very pleased to not be talking with you about that for this period of time, but to talk with you about the Healthcare Coalition. The Healthcare Coalition is an organization that we formalized back in 2007, 2008. But its work really began in pre-9/11 days. We've had a hospital planning committee across a very large region, which I'll show you in just a minute, since 1998 to talk about preparedness in the hospital system for any kind of an emergency. As we got past 9/11 and the anthrax threats and different funding streams began to come into public health and the healthcare system, recognizing that we weren't able to respond to the capacity that as a nation we would like to. We began to evolve. And so the initial dollars, when they came from the Assistant Secretary for Preparedness and Health, still came to the hospitals, and we were still focused on being in a hospital planning committee. But it was really about enhancing the hospital's capacity to respond through security measures, enhanced communications, including actual communication equipment, being able to surge for a large influx of patients, that type of energy, as well as enhancing the public health system around surveillance. Our lab capacity and the ideas of building a bioterrorism level 3 lab came out at this time, which we made happen in 2004, as well as communication enhancements. And then we evolved into a healthcare coalition, recognizing that as a nation, it's not just about our hospitals. It's about the whole healthcare wraparound system and public health integration into that would make us better suited to be able to respond to any kind of emergency that was medically oriented, so that we could let hospitals do what hospitals do and decompress them into the other aspects of the healthcare system to do what they do best as well. So our healthcare coalition covers it's Region 9. It's been our state is in 9 regions. We are by far the largest with 10 counties. But our healthcare coalition has 122 individual agencies and 312 current members. And what that looks like a little more specifically, there's 19 hospitals in our region, most of them critical access hospitals. And then we work very closely with our Idaho partners and the 5 hospitals in northern Idaho. In addition to that, there's clinics, specifically the federally funded community clinics. There are 8 of them identified here on our map, but one we couldn't figure out how to get Chaz in 7 different places. So there's actually 15 federally funded clinics that are part of our healthcare coalition as well. And we have 3 tribal partners as well as our public health partners. So there's 8 local health jurisdictions in our region and 3 tribal health jurisdictions with Spokane, Colville, and Kalispel tribes. In addition to those most formal partners, we have 80 other partner organizations that represent mental health, blood centers, emergency management, law enforcement, fire, some of our traditional responders, as well as the wraparound allied health service partners. So we have a large task in trying to help every organization identify themselves in the work of the Healthcare Coalition, and certainly in coordinating all of our plans so that we can be at the best when we need to be in any kind of an event. So what have we been doing sort of since 2008, 2009, when we really formalized our healthcare coalition across all these partners? The needs of most of our partners was really around being able to share staff and stuff during a medical surge event. And so a lot of the work was around establishing agreements and then actually testing those agreements, and how could we get a medical provider quickly privileged to be able to practice in an institution that's outside of their system. And all the way down to non-medical staff that would need to help out in different environments. We've helped build response plans, alternate care facility plans, behavioral health response plans, a resource coordination plan, disaster medical control center, which is a function of being able to move patients from the scene to the appropriate level of care in the appropriate location in the least amount of time. And that's the role of that whole DMCC. And then we've worked with individual institutions on their own evacuation and shelter-in-place plans, as well as their continuity of operations plans. Our goal, collectively, is that everyone that provides any aspect of healthcare is able to keep their doors open doing what they do, so that patients can be served by them and not go to other places that are being inundated with different types of emergencies. Equipment's certainly been part of it. We have a portable morgue. We have decon trailers at every hospital. Decontamination trailers at every hospital. Alternate care facility trailers. Evacuation supplies, pediatric caches, ventilators, generators, the list kind of goes on. But in the early days of the grant from the federal government, it was a robust amount of money, and it was designed to enhance the system and identify items that could be easily shared across hospitals and clinics. The Healthcare Coalition has helped financially to support the Medical Reserve Corps in the building of our volunteer base for Eastern Washington. We regularly do training and exercise. We assess what each other's capabilities are and where we need to spend energy each year to help enhance those capabilities. And mostly it's about fostering relationships. By definition, as a coalition, it's about everybody seeing themselves in the work that we do. And when things get stressed, and I will mention the E word at the moment because we're in one of those stressful times in terms of the healthcare preparation, it's the relationships that really help us move quickly through our preparedness actions to get better prepared if we need to be. Another area of focus is believing that education enhances our capabilities. And in the these are some activities we've done in the last year. The business resiliency training to help individual organizations have continuity of operations planning. We brought in a FEMA reimbursement training so that if it became a federally declared disaster, they'd be in a position to recoup costs associated with that disaster for their facility. We actually tested emergency medical staffing across several of our healthcare system partners and worked out some of the wrinkles associated with that. And WATRAC expansion. WATRAC is our hospital bed tracking system in Washington State that we adopted in Eastern Washington about 3 years ago, and that just continues to expand so that each of the hospitals and the EMS providers can see what types of beds are available at different hospitals and whether their emergency room is on divert at that moment or not, so that the ambulances know exactly where to go without wasting time. Like I said, it's all about relationships, and some of the examples of how those relationships played out this past year is the Healthcare Coalition was reached out to pre-position the alternate care facility trailers pre-event. So they were pre-positioned for Bloomsday, for Hoop Fest, for the Air Fest at Fairchild, just to have, they're not far away, they live on a regular basis out in Colbert, but to bring them actually into town and have them very close if an incident were to happen during one of those planned events. Department of Health reached out to Region 9 to bring some of their assets to Eastern Washington during our wildfire response. We regularly work with Idaho in what we call an Idaho collaboration, and those 5 hospitals that you saw on the map earlier with their healthcare coalition. And we have a very engaged hospital planning committee as a subcommittee of our healthcare coalition. part of our mission when we meet 6 times a year as a healthcare coalition. And part of that is business and trying to move processes and planning and communication systems along. But we also want to share experiences and real-world knowledge of what went well and what didn't go well when people have responded. We most recently had somebody come, our ESF, our Emergency Support Function 8 partners, which is Health and Medical Response, from the Oso mudslide, came and presented to the Healthcare Coalition in September to share what their experience was as a public health and medical response, mostly in that instance dealing with the fatalities associated with that incident. But we got to learn firsthand from what their experiences were, so it enhances what we're doing. And then the National Healthcare Coalition Conference is in its 3rd year, and it's a conference by coalitions for coalitions. It's one of the few conferences that isn't driven by our federal government partners, but so we really use it as an opportunity to learn from each other as well. Part of what keeps us going is that we've gotten recognized in the last couple of years. We were recognized last year by the National Center for Disaster Medicine and Public Health as one of only 9 coalitions in the country to be paying attention to in terms of the actions that we're doing, how we're communicating with each other, and how visible we are to each other as this vast number of partners in a broad region. And we were named earlier this year by the Washington State Public Health Association as one of the public health champions. So I put together this presentation pre-Ebola, and my jump-off point for this little talking was it began with a ventilator request, and this is referring to an incident that happened a couple of summers ago when there was some severe respiratory illness early in April, May, and the sense was that we might run out of ventilators, and so there was a reach out to the partners to just start getting their ducks in a row between Kootenai Medical Center and our Spokane hospitals in case we needed more ventilators or to move patients who needed ventilators into a different environment. This has also held true as we're doing the Ebola planning, is reaching out to support each other to make sure all of our healthcare system partners are able to identify, isolate, and inform about a potential patient, and then what we do in terms of caring for a patient. All of those relationships and how we move into response, I think, has been dramatically enhanced by the work and the relationships over the long term for the Healthcare Coalition partners. The federal dollars used to completely dictate what we did as a healthcare coalition. From the federal level to the state and the state to us, there were deliverables, as we all are familiar with different grants. But at the local level, sometimes it felt like there was a disconnect in terms of what the federal government wanted to have happen and what we needed to do in terms of the nuts and bolts of actually making it happen on the ground. But as the dollars have dwindled, so has the loosening of how we spend those dollars in the best way that we deem appropriate for continuing to move our mission forward. And so this past year, we've engaged in a really robust strategic planning process to identify what is that direction and what is it that our partners really want to be the focus of the work we're doing. And what we're learning is they want the Healthcare Coalition to be more of a response organization to help orchestrate response, and we're kind of feeling that right now and wish we were a little bit further down our path of planning so that we could more easily figure out exactly how to support the partners, but we are, and we're muddling through it. But continuing to help our partners with their accreditation needs within their institutions, planning, et cetera. So we're actively engaged in that and anticipate that we'll have a new strategic plan by June of this year. June of next year, 2015. Because our ultimate goal is that we'll have a sustainable healthcare coalition in the absence of federal dollars. And it's building that value and supporting our partners that will help us achieve that. So I appreciate the time this afternoon. Any questions?
Okay, any questions? Good report. Good. I think we have a better understanding of what the coalition is about.
Thank you.
And how important it is. So thank you very much. Thank you very much. Okay, with that, let's go to number 10, board member check-in. Starting with you, Keith. Anything?
I'd just like to mention one thing. I don't know, some of you may have attended the Blue Zones presentation the other night at the convention center. It's a National Geographic author who's gone around the world and looked at communities that have long-lived individuals, centenarians for the most part. I'm not going to go into a lot of it, but I did notice there were a number of regional health district staff there who maybe are going to talk about it more here. But the thing that I took away, which I thought was very interesting, is that they have gotten some significant grants to actually change the physical environment of a number of cities in the United States, which then transforms people's behaviors into more healthy behaviors. So they're not trying to change a person's behavior either through regulation or education. They're changing the environments within which people work and play, and that's what's creating a healthier environment. Just an interesting twist on sort of the work we do in public health and in cities and counties. And so it's a fascinating book. If anyone is interested, it's called Blue Zones. And he's actually written 3 books about these same principles. But that's sort of my takeaway, and I thought it was very interesting part of the process.
Very good. Thank you, Keith.
Yeah, thank you.
Shelley? John?
Just a brief word to commend my fellow participants in the governance committee, Bob, Shelley, Keith, Chuck. Part of what you saw today was the legislative process that have come out of that discussion. And I think that has been a really good discussion on governance this year. Appreciate everybody participating in that.
Okay, thank you. Bob? Ed? Dr. Joel? Amber?
I just had, I wanted to make a mention of someone from the health district who's been really helpful on a project, and that's Jennifer Hansen, who works in the Neighborhood Matters program. She and I have been co-chairing a committee of the targeted investment area, which is a targeted area where the city's trying to focus public resources, whether it be streetscape improvements, whether it be housing improvements, access to social services or education. So working on both the environment, as Keith is talking about, but also the needs of people in that area and, reducing crime. And one of the issues in that area is prostitution-related crimes. And so Jennifer and I have been the co-chairs of the Human Services and Community Outreach Committee. And I just want to say she's been doing an amazing job. And it's a really, the prostitution-related crimes is kind of the thing that's come out the most that we need to work on to address health issues and safety in the neighborhood and the economic future of the neighborhood. And so she and I have been working with a lot of community partners on developing strategies and doing some assessment work hopefully in the next year. So I just want to say you have some great staff, and Jennifer goes above and beyond probably the call of duty. So I just wanted to recognize her work. And number 2, something that the city and the school district, Spokane Public Schools, and a lot of our partners, this is just kind of a new development, but we're looking at applying for a Promise Zone designation for most of Northeast Spokane. And this has come out of many, many years of developing strategies to improve graduation rates in that area. There's a lot of money going into after-school programs for Shaw and Gary middle schools. And Spokane Public Schools has this vision, working with the neighborhood and the city, to really improve the lives of children and the future of the folks in that neighborhood. And so just keep an eye out. We'll see if we can get the application in by the deadline, which is in about 3 weeks. But there's a lot of great people working on this Promise Zone, and I appreciate the health district's support and participation. Thank you.
Thank you. Kevin?
I just wanted to say a few words. Bob did a good job of summarizing the strategic planning work group function, but I wanted to say how impressed I was with the workshop, the all-day workshop that we had, particularly with the division heads that came in and participated. They had a lot of great input, and I was particularly impressed with how well they represented their employees' views as part of this process, so that the mission, vision, values, the strategic plan I think that's being crafted is actually a true representation of the SRHD employees, and I hope that when that comes forward for the board, that we'll remember and recognize that there is significant input, and it's very heartfelt and energetic input from the divisions.
Okay. Thank you. Al? Nothing. And Chuck has nothing at the time except thank you very much. Do I have a motion to adjourn? It's been moved, seconded. All those in favor? Aye. Again, thank you very much.